So as we can see in this case, mutation testing was quite important. Why do we do mutation testing, when, and what are we looking for? Any clinical situation where we're concerned that the disease may not be responsive to therapy any longer, any loss of a previously established response, particularly anything above major molecular response. In essence, if someone loses a major molecular response, a complete cytogenetic response, or even a major cytogenetic response, those become increasingly important scenarios where mutation testing is important. Mutation testing may be more important in advanced disease patients because the frequency of mutations is higher. Other pH-positive leukemia settings like pH-positive ALL, for example. But in chronic phase CML, again, a lost milestone or clearly a missed milestone, if someone never achieved a cytogenetic or molecular response and by guidelines was meeting criteria for treatment failure, those are situations where mutation testing offers a good yield. Maybe not as good as we think, though. About half of cases in general, based on the research that has been done over the years, half of cases of clinical resistance are associated with a mutation. Amongst those, there's a subset that may have specific mutations that would drive treatment choice. And one of the most important, again, is the T315I mutation. That really drives treatment choice currently and points us towards one agent, ponatinib. Other mutations may point towards or away from other medications. There are mutations that are particularly sensitive to nilotinib and are resistant to dasatinib and bosutinib, for example. Those are not common, but they can be seen. And in turn, there are mutations that we may see more frequently after imatinib or nilotinib that are better served by treatment with dasatinib, bosutinib, or ponatinib, for that matter. And so, in summary, mutation testing is important for a missed milestone or a lost milestone. About half the time is informative, and in a fraction of those cases really does drive treatment choice, so is worth doing, and particularly for the notion of not missing a T315I mutation. This case also raises the question about the indications for ponatinib. How do we use ponatinib and what's the right setting? A patient with a T315I mutation really doesn't have any other easy treatment choices. There are historic agents we can use that we've used in CML before the TKI era, and omacitaxine offers a treatment choice for patients with multi-drug resistance or the T315I mutation. But currently the FDA indications for ponatinib are for patients with a T315I mutation or for a patient in whom no other TKI is indicated. How do we define that? It can be a difficult journey for patients, and some have either a combination of resistance or intolerance to multiple agents, or both. And there are clearly a fraction of patients in whom either drug resistance or intolerance, or both, have let us or closed the door on all the other available TKIs, and ponatinib makes sense for those patients. So beyond just patients with a T315I mutation, patients with multi-drug resistant CML, as I like to call it, or patients with a mixture of resistance or intolerance. In my view, I think patients who have fairly high level resistance to initial treatment with a second generation inhibitor aren't really well served by using another second generation inhibitor as a second choice. We ought to think more carefully in those patients about using ponatinib earlier on, as their chances of response are clearly lower based on available data between switching to another second generation TKI versus switching to ponatinib.